and mechanistic molecular pathways. For example, and I should preface that by saying different investigators champion overlapping but non-identical sets of mediators for these outcomes, which I think you know is true for most things in asthma. But for epithelial damage, this author summarizes evidence that TGF-beta and environmental factors acts on epithelial cells to lead to that phenotype. Similarly, it acts on fibroblasts to create some of the subepithelial fibrosis and connective tissue increases. If we look at mucus production, there are a number of cytokines, including IL-9, IL-13, that are especially dramatic in mouse models and may play a role in human mucus production increases as well. VEGF is identified in angiogenesis as a key mediator. And for smooth muscle mass, there's quite a long list of suspects, and that include direct effects on the cells that are there, as well as increasing migration of precursor cells to add to the smooth muscle grouping. But let's revisit, and I want to stay focused on the question of the clinical utility of these changes. Can they help guide diagnosis, prognosis, and treatment? If so, we can start with a basic question, and is there an association of these features to the clinical question at hand in a simple dichotomy, yes, no. And this is illustrative of many early studies where people compared asthma or normal and measured one or more of the things I've just itemized. And the answer is yes, there is an association, and this captures it quite well. My laser is out, but I think actually good practice for presentations is to avoid the laser, so let's see how I do. I think you can see that on the left, these investigators turned to special stains to highlight the so-called basement membrane. They measured it, and they measured it in about 35 asthmatics and about 20 normal subjects. And I think you can see they found a difference as predicted by the definition. A bit of a circular definition here, but this is the evidence behind including this concept in the airway remodeling idea. The other thing I think is worth noting here is the variability within the asthmatic groups, with many of them overlapping with the normals. Now, let's get a little more precise. Can we use these features to analyze or compartmentalize severity? In this set of studies, these investigators took samples. The A panel is a person with asthma and a prominent pink stripe, that is the so-called thickened basement membrane. The B panel is one of their comparison groups, in this case a biopsy of someone with COPD. They take their studies, and they're illustrated in C and D, and use two different quantitative approaches to measure the thickness or the intensity of the expansion of that basement membrane compartment. They've outlined in C, there's a method that uses a ratio of area to length. D is the simpler one, perhaps. They just, at multiple points, measure the thickness and average that. And the upshot of this approach, trying to link it to severity, is summarized here. And let's just focus on the second of the two methods ascribed to Sullivan and co-workers. And you can see there are four groups that were compared here: controls, mild asthma, people with COPD, and severe asthma. And they're quite a large number per group, actually. They measured the mean length, and as you can see, compared to controls, mild is got a bigger basement membrane thickness, and it's even bigger and largest in the severe asthma group. And there's some change in COPD, consistent with two observations. There is a linkage for this phenotype, the thickness of the basement membrane, with severity, and it's not 100% unique, this change, to asthma, seen in some COPD biopsies as well. Another way to look at this was offered by these same authors, which is to another clinical feature, which is the predicted FEV1, or the actual compared to predicted, and that's on the x-axis. So you're worse off as you move closer to the y-axis, and the thickness of the basement membrane is plotted as the y-axis. The empty circles are the severe asthmatics, whereas the filled circles are the mild, and I think you see there's a pretty good distinction, but also there's quite a bit of variability, a finding that's pervasive in all of these studies. Another feature that has been subjected to the same kind of analysis of that list of airway remodeling components is the smooth muscle mass. And in these studies, these workers used immunostaining for smooth muscle actin to help identify and quantify the mass of smooth muscle. On the left, they found these were the individuals that were, the group of patient study here were all classified as severe, but some had chronic persistent airway obstruction functionally, and some had intermittent obstruction or were less severe. That group, the less severe, is on the left. The chronic persistent obstruction group is on the right. And I think you can appreciate in this so-called representative photomicrograph that they saw a big difference.
No extra pointers, but you can use the mouse.
Oh, thank you. Yeah, all right. I see that. Thanks a lot. That's
This is going again.
Oh, it charged up. Thank you. All right, thanks a lot. The quantitative version of this is shown on their summary graph here, where they plotted the smooth muscle area versus FEV1, and the solid triangles are the chronic persistent or more severe asthmatics, and there on the left they have the worst FEV1 as percent predicted, and they have the most muscle mass. But again, there's a fairly good splaying around the line for this feature. So let me summarize a maddening number of other studies, probably in the close to 1,000 or so, depending on how you do your filtering, that look at these features versus some phenotype in asthma. And mostly, it's clear that they do confirm the association of these features to whatever they're measuring, FEV1, self-score of asthma symptoms, or other pulmonary function tests, etc. However, in general, there's a lot of differences and disputation among them as to which feature of the 5 or so that I've itemized, and you can split those a bit if you wish, and to what degree they're actually sensitive and specific for the particular phenotype. So while the big picture is logical, the worse off you are, the more you have of these airway remodeling features, the fine print is fuzzy and not very useful in terms of actually predicting who fits where in the spectrum of asthma. And one review summarizes a second problem, which is not only is it somewhat frustrating in terms of diagnostic utility, in terms of the original dream of revealing insights into mechanism, it appears that although there's a big set of data that associates remodeling with loss of lung function, there's no causality established yet. In other words, some people favor changes in the vasculature, the angiogenesis component. Others favor the smooth muscle mass. For a while, the basement membrane was thought to contribute to constriction problems, etc. I think it's fair to say there's no good link between these changes and the true pathophysiological effects on airway function. I want to focus especially on the limitations of these findings as a reporter of disease activity. One major limitation is even when well applied, I think you can see this requires quantitative histopathology with detailed measurements and imaging, etc. And it's really a clinical research tool. It's not a diagnostic tool like the FEV1 or the other pulmonary function tests that are much faster, cheaper, and better at providing the information for clinical use. And secondly, and I'll review in detail now, there's striking evidence that many of these features are essentially reporters that disease has been there, either now or in the past. And it's not clear that they are especially useful if that is true for each one of them. And the reason I say that comes from two, I think, very striking studies that focus on one and a little bit on some of the other features that are called airway remodeling. And these studies lead to the conclusion that you can have substantial airway remodeling changes present in people with so-called complete asthma remission. And what do we mean by that? So these are two studies from Jirke Postma's group in the Netherlands. They're summarized here, and I'll mix and match the data. But I think what I want you to pay attention to is she has about 20 people that she's followed for 20 to 40 years. That she calls complete asthma remission. They were clearly in the system, they had symptoms, they're in the, but over time they've stopped. And they have a normal FEV1, they don't respond to bronchoconstrictors at all, and they have these other features with essentially close to normal. They have another group of patients, about 45, that they call clinical remission. Everything else looks fine, but if you give them a little bit of a bronchoconstrictor, they do show some responsiveness. So there's something still lurking in this group. So they acknowledge that and call it clinical remission, but not complete. And they have some patients with current asthma that are much more sensitive and have other features that are characteristic of active asthma to compare. So they've done extensive studies on these, including biopsies, to explore what's going on with these people, including the asymptomatic complete remission group. When they do that, they find that when we look at eosinophilic inflammation, the blood eosinophils up here in the complete remissions are very low, almost similar outcome in the clinical remission group. Some trend in the current asthma on inhaled steroids for a little bit higher level. Sputum eosinophilia is the same, and markers of eosinophils within the tissues, more about that in a moment, follow this general lack of eosinophilia in the complete remission group, eosinophilic cationic protein and eosinophil peroxidase assays here. Here's an example of some of the biopsies they obtained from this patient group. Really not important to go into which one is which because they're very similar and they're very mild at best. This is a group of mild asthmatics and in complete remission. They have the same level of, there are some eosinophils detected with eosinophil peroxidase immunostaining at about the same level in all three groups. And when we look at the more detailed analysis, they find identical numbers of macrophages, neutrophils, and eosinophils in the bronchial biopsies of all three groups. The one difference they found was the immunopositivity for eosinophil peroxidase was increased a little bit in the remission group that's clinical, the middle one, and in the clinical asthma group. But everything else, all the other T cells, macrophages, neutrophils, and eos are about the same. And importantly, and I think this is probably the death knell for thinking about basement membrane thickening at least as an important active marker, these folks who've had no asthma symptoms for 20, 30 years have a thickened basement membrane that's comparable to that of the current asthmatics, at least in this mild group. So it really becomes clear to me that this is really, this component of airway remodeling is best thought of as scar or something like scar formation, and it can stay with you for a long time. But that certainly limits its potential utility for classifying people or further clinical utility, I think. This is the summary of the dot plots to show the spray of the individuals. The data is summarized here, but they also looked at goblet cells, which didn't differ. That's the first line. So the mucus component in this group of patients was about the same as well. And you see some other markers of airway remodeling, not different in this comparison of completely asthmatics in complete remission versus current asthma. Now, one other point before summarizing this section of the presentation is that I mentioned that airway remodeling was already acknowledged by some of the defining reviewers as occurring in other disorders. Here's one example. You can see features like this if you do autopsy studies in Vancouver versus Mexico City in people who are not smokers who have died of car accidents or other disorders, and just look at their airways. And this is a group interested in pollution and is interested in the effects of high pollution exposures. A and B are from Vancouver, nice thin airway walls. C and D are low and higher magnifications of airways, and they have quantitative data to back this up that show increased thickening of the fibrous component, collagenous changes, and the smooth muscle component in these non-asthmatic, apparently healthy, in terms of respiratory health, individuals in Mexico City linked to pollution. So airway remodeling is both, has its limitations in a number of ways, but they include the non-specificity, in some cases, crossing over into other disorders. So for most asthma, I would say histopathology to assess airway remodeling is not needed, nor is it the best way to make a diagnosis. It's associated with pathophysiologic changes, but the causal role of structural changes is unclear. Some features are present in complete remission. At least a mild amount of mucus hyperplasia and the basement membrane changes were present in those two studies we just reviewed briefly. They did not look at smooth muscle mass or angiogenesis, so the question remains open for those features, but nevertheless, it's looking like at least some parts of airway remodeling are present in complete remission. And some features are present in other airway diseases. So I think it's fair to summarize in terms of specific clinical utility for most cases of asthma that it's absent. So looking at my clinician colleagues in the audience, I think it's fair to summarize most of the time you are not performing biopsies on patients with asthma, and my message is keep up the good work. All right, now you're probably despairing and pitying the poor pathologist, all this skill, all this equipment ready to go, but no place to go. And the metaphor I was thinking about was the Maytag repairman whose product is so good that his services are not needed. But I realize this is a cultural reference that is probably lost on most of the audience. So maybe the appropriate one is your drawer full of smartphones from 1 to 2 years ago that were really cool, had lots of capabilities, but somehow just don't have any use. Okay, but there is a 10% solution. There is a potential role that I want to discuss now for histopathology to help evaluate and think about severe refractory asthma. There are numerous synonyms to describe the fact that 5 to 10% of asthmatics are difficult to control, don't respond as well to available drugs, and continue to have signs and symptoms. So much so that there are specialized units that focus on evaluating severe asthma patients, and one exists, for example, at the Royal Brompton Hospital in the UK, and this is a review from Dr. Chung about their approach to investigate the severe asthma phenotype. And they do a whole bunch of tests here, but among them is the concept that they can consider or worry about alternative diagnoses or comorbidities, and some of those are listed here. And in fact, in one series where they looked at 100 consecutive patients referred to them as a tertiary center for difficult or severe asthma, they found that 12% had been misdiagnosed and did not, in fact, have asthma. And they offered this list. And so here's our side trip, because as part of what histopathology can do for you is we can help you work through some of these alternative diagnoses. And for example, allergic bronchopulmonary aspergillosis has characteristic problems with mucoid impaction that result from the allergic response to some aspergillus colonization of the airways, dramatically captured in this resection specimen. All those yellow-white balls are airways expanded with mucus impacting the airways. Sometimes clinicians can go in there and grab them and remove them through a bronchoscope and extract lovely specimens like this that characterize the problem here. On biopsy, mucoid impaction has characteristic features. We see that filling the airway right here, and histopathology can identify it. We can often identify the degenerative scant amount of aspergillus present in these specimens with a silver stain in the inset. And while we're busy, we can also see some Charcot-Leyden crystals sometimes. Churg-Strauss syndrome is another of these alternative diagnoses where histopathology is critical. There we have in the upper panel at low power necrobiotic nodules that on high power reveal an eosinophilic vasculitis. That big red thing in the middle is a vessel being destroyed with a thrombus in the middle, and percolating around it and through it are eosinophils, and this is diagnostic of this syndrome and would be helpful if that was the cause of the shortness of breath and clinical package that brought this person in. Obliterative bronchiolitis can also present, apparently, and is on the list from the Brompton. Oops, and we can help with that. The left one shows constrictive bronchiolitis, a peculiar variant that features connective tissue strangling airways, easily diagnosed on transbronchial biopsy. And more commonly, we have obliterative bronchiolitis that starts with a fibroproliferative exudate within the lumen and fills it, as seen on the right. There are eosinophilic syndromes that are easily diagnosed at least identified with